again spine consultant at JP Hospital, Noida, for his talk on anatomy and approach to Camden's triangle, and he will also touch upon the necessary considerations for public spine surgery.
So, from the last 4 decades, the triangle Camden, indications of using the Camden's triangle increasing. He initially started with contained herniations, and slowly it went more, and Lucho started doing sequestered and migrated his herniations later in published his work. Then we can use it for biopsy, puff drainage, cystitis, and now the fusion, olive, caliph, and the endotheliums, as we'll be talking about in detail today. So, general considerations is basically the foreign spine area and its relationship to the disc spine and the intervertebral disc area and part of the spinal nerves nearby. So, basically, it's the exiting spinal nerve, the root of the cranial level, the superior end plate of the inferior vertebra, and the superior articular facet of the inferior. So, we say often talk about the triangle as it is a 2D structure, but in reality, it's a prism. And we have the posterior superior articular facet, and on the medial side, we have the traversing nerves. So the clinical relevance would say basically it's a minimally invasive zone from where you can go in, and you can actually avoid the thecal sac and the vascular structures. It reduces the recovery time and the soft tissue trauma. So basically, it is used for transfemoral discectomy. And when you do transfemoral discectomy, you go more shallow, you go lateral. And when you do olive, you go more anterior thirds. The possible complications of using this area would include nerve root injuries, the dural tears, and the strategies to counter that would include neuromonitoring, as very regularly used by Dr. Basi, a direct visualization as an endoscope, and awake surgeries as pioneered by Dr. Varun. Comparison with interlaminar approach, it has a lot of safety, and it's a table which would list a lot of things which would include nerve root safety and less scarring. When you go from the back, there is much more scarring in the tissue, and it's easier access. There are some anesthesia considerations in local anesthesia and conscious sedation. We have to actually check whether the patient is really cooperative. And more than patient cooperative, at least in Indian scenario, we have to check in that we are comfortable with the anesthetist who is trying to help us get through the local anesthesia. Sometimes in some hospitals it's very easy. And sometimes in some hospitals it's quite difficult to actually get that kind of conscious sedation when you can really perform the surgery well. The patient positioning is very important when you start doing local, because if the patient is irritable, then the surgery cannot progress further. And relatively, a shorter surgery to start a local anesthesia would be better, like a discectomy or a single level fusion, than doing multiple levels, at least to start with. And drugs, text medicine, and rental come to rescue. In some cases, spinal anesthesia can be done. In GA, the most important mainstay would be neuromonitoring. The workup of the patient and post-operative early if the patient requires stay longer. So in conclusion, it's a very important minimally invasive corridor, and anatomy training is very important. Any Q&A?
Thank you, sir. Now, next, I would like to invite Dr. Amit Rara, sir, who is a leading senior spine surgeon who has traveled all the way from Ahmedabad. So, we'll be hearing a talk regarding history and evolution of OLLIX and is there really need for another interbody fusion technique. So please welcome Dr. Amit Rara, sir.
Well, thank you very much for inviting me for this. The first topic time for life surgery and career engineering. And with none other than one of the pioneers of the world doing this course. I think it's a great advantage and we have to take all the advantage of that. This all the way travel, not from Ahmedabad for me, but all the way from where the Dr. Bharat has come. So I'm just going to put the ball rolling. We all feel that really for global LIF or transcranial interbody fusion is a novel technique. But if you want to learn these techniques, you have to go to the roots. And if you go to the roots, then you will find that a technique has not evolved in one day. They have been evolved for years together. I would say it is more than 90 years or 80 years that this is actually evolving. So it's better that if you know what the intricacies in that, you become much